Hello, everybody, and welcome. My name is Amanda Jeffery, and I am the head of sexual and reproductive health at Metro Charity. And I am joined here by my lovely colleagues, who I will introduce in just a moment, to talk about our very exciting and innovative SHIFT project. And Shift, we are looking to support and enhance the sexual health of people in the UK and abroad who are over the age of 45. So before we get into anything further, I'll introduce my colleagues. I'll jump over to you, Mun-Yee, if you want to introduce yourself.
Hi, everyone watching. My name's Mun-Yee Tung. I'm a consultant in sexual health and HIV, and I work for Kent Community Health Trust, which is an NHS trust down in Kent. And we are known as PP3, hence I've got that lovely number attached to me. And we are one of the partners who are going to be delivering what the SHIFT model comes up with and looking to empower and improve the sexual health of people aged 45 and over. And I'm very pleased to be part of this project and part of this panel today.
Thank you, Mun-Yee, and welcome. Ross, I'll jump down to you.
Good afternoon, everybody. Thank you very much for having me on the panel today. I'm Ross Bosley. I work for public health within East Sussex County Council. And East Sussex County Council is also one of the partners in the SHIFT project. Thank you very much.
Thank you, Ross. And over to you, Steve.
I'm Steve Chevis. I commission sexual health services in Medway. And being 51, I've got a vested interest in this project. It's a great project to be part of, and it's a lot of fun.
Thank you, Steve. I have to say, earlier I was reflecting on the age group of the project. Often I work with young people, and I realized this afternoon with some dismay that I'm closer to this age group project than I am to the young people that I work with. So I too have a vested interest. And just quickly to say, so we've all sort of touched on what SHIFT is, but just to reiterate, it's a project that at its core is designed to support and improve the sexual health of people who are over the age of 45. And what that means to us is not only to support people who might be struggling with some sort of pathology or illness or suffering, but also to make sure that people over the age of 45 recognize and are able to obtain a positive and good sex life that's full of pleasure for whatever that means to them. So we don't just want to focus on the negative aspects of sex or the negative aspects of aging. What we want to do is really look at the fact that aging is a reality, and sex is a positive thing, or can be a positive thing for many people, and we want to make that possible. We want to help people to have the most positive experience that they can in whatever kind of relationship or not relationship they might be in. So just to give you a bit of information about the project, SHIFT is a European project. So we have partners in the UK. So that would include Metro Charity, which I am from, the East Sussex County Council, which Ross is joining us from, Medway Council, which Steve is joining us from, the University of Chichester, and my colleague Tess is joining us in just a moment. Here she is, actually. I'll just let her. There we go. Hello, Tess, and welcome. Sorry, Tess is having some technical difficulties. Welcome to 2020. Tess, just before we continue, would you like to just introduce yourself and say what your role is in the project?
Yeah, so like Amanda said, I work with the University of Chichester, and we're kind of the evaluation partner of the project. And I'm a research assistant with SHIFT, so I'm just helping out at the moment with analysing all the data that's coming in.
Wonderful. Thank you, Tess, and welcome. Oh, and we've got Ian as well. Welcome, Ian. I'm just going to jump you. Sorry, we've had some technical difficulties this afternoon. As I said, welcome to 2020. Ian, would you like to introduce yourself quickly and just what your role in the project is?
Hi, everyone. I'm Dr. Ian Tyndall, and I'm a senior lecturer in psychology at the University of Chichester. And as Tess was just saying there earlier, we are the evaluation partner in the whole SHIFT project. So one of our major responsibilities was putting the surveys together and releasing the surveys online, and also to analyse the focus groups and telephone interviews that were conducted with our participants in the study. And so we'll be evaluating each stage of the project and the model developments overall.
Great, thank you, Ian, and welcome. I'm so pleased you guys could both join us. So yes, as I was saying, I think I've actually introduced all the partners who are here. So we've got the, except for Mun-Yee, so we've got the Medway Council, which I said, East Sussex County Council, the University of Chichester, and Mun-Yee is from, I can never get it right, the acronym, but it's KCHFT, which is the Kent Community Health Foundation NHS Trust. Is that right, Mun-Yee? Yeah, great. We also have partners from the Kent County Council in the UK, and then in Europe, we have partners who join us from the Netherlands as well as from Belgium. And we are led by the wonderful Health and Europe Centre. The funding for the project it's called an Interreg 2Cs European project. And it's funding that is given for projects that geographically look at the kind of crossover areas between sort of the southeast of the UK and the northwest, I guess, of Europe, to try and look at, what we do similarly, what we do differently, how we can support one another, what information and resources we can share. So it's been very interesting working across multiple languages and with, different health systems. So today we want to do a few things. The first one is, of course, we wanted to tell you about Shift. The second one is that we really want you guys who are listening today to engage with us with your questions, your thoughts, your comments as much as is possible. And we really want to let you know, we'll remind you really that we're still here. It's been a very strange year for all of us. A lot of people are forgetting about their sexual health, or they're not forgetting about it, but they don't really know where to go to support it. So we want to just remind you all that we're here, we still care, we really want to support you, and we want to let you know a little bit about what we're doing. Now, without further ado, one of the things that we hear a lot from people is that they want to go see a clinician. They're having something that's going on that's a bit funny for them. They're not sure. They have some questions. They have some concerns, but they're very anxious about going to see a sexual health clinician. And of course, this is something that we as sexual health experts think, well, why would you be nervous to come see us? We're all so lovely. But of course, for people who have never had that experience, they're very nervous. There's a lot of anxiety that's related to it. And so we thought we would make you guys a wonderful video that looks at what a very typical sexual health consultation would look like. So I've got my 4-year-old running around in the background. This definitely is 2020. He's got some candy. It's very exciting, isn't it? Yeah, I can see that. Anyway, so what we did was we did sort of a mock consultation. So Dr. Mun-Yee Tung, who, as you know, is here with us today, did a mock consultation with one of our project partners. We created a fellow named David who is having some pain when he is weeing. And we thought we would share it with all you today. You can hopefully watch at home now, or you can watch later. And we wanted to just alleviate the concerns that people might have about visiting a clinic. Also, a very common thing that people come to a clinic is, pain when weeing, or pain during or after sex. So we thought we would share it with you. Mun-Yee, before we go over to the video, is there anything that you want to say about it, or by way of introduction?
Thanks, Amanda. So yes, I think it was trying to find a way to help reduce some of the anxiety about contacting sexual health services. Not everyone needs a sexual health service, which absolutely is fine. But if someone, like you say, does or is thinking about it, maybe through watching the video and seeing what happens there, it might kind of help reduce some of the anxiety, or even prompt some questions that you can write down before you go. So either way, it just hopefully helps kind of show what we do. And especially during, as you say, crazy COVID lockdown, it just means just to let them know that we're still open.
Wonderful, thank you. All right, well, let's watch the video. And if you guys have any questions, do keep them till the end, when we'll be happy to answer them. And of course, at the very end of this session, we will give you our contact information, so you can always write us with anything that comes up in the meantime. Now, I'm going to ask our wonderful producers who are looking in the background if they can play the video for us.
Hi, David.
Hiya, you're all right.
I'm good. My name's Mun-Yee. I'm one of the sexual health doctors here at the clinic, and I see it's your first time here today.
Yeah.
Obviously, it's a really strange place for some people to be, so please don't be too worried. And I do need to ask you some questions just to find out a little bit about why you're here. And some things might get a little bit embarrassing, but please try not to feel too embarrassed, because we've kind of heard everything before.
Okay.
Before I start, can I check some kind of basic personal information, if that's all right? So first of all, can you tell me your full name?
David Jones.
Fantastic. And can you tell me your date of birth, please, David?
8th of December 1966.
Fantastic. Those details, and we've got those correct. Brilliant. So, David, how can I help you today? What brings you to my clinic?
So a few weeks ago, and I've never had any problems down there at all, ever.
Mm-hmm.
I started to get some problems down there when I was going to the loo. It was burning a little bit. It was quite painful.
Okay, so a couple of weeks ago, out of the blue, you developed this kind of burning when you had a pee. Is that right?
That's right. Yeah, but
Okay.
I went to see my GP, and he gave me some tablets. He said it was like a water infection.
Yep.
So he gave us the tablets, and I took them.
Mm-hmm.
But it hasn't cleared up. It's just the same. So I went back, and he suggested I come and see you.
Okay. Well, as you say, the approach sounds very sensible. Urine infections are not uncommon. However, they tend to be a little bit less common in men. So maybe if it's not quite a urine infection, it might explain why those antibiotics didn't work the first time.
Right.
How long were the antibiotics you had for?
A week.
A week. Brilliant. And you took them all, you didn't miss anything like that?
No.
Excellent. And just kind of looking at your general health, is that okay, David? Do you have any other like health conditions you see your doctor for? No,
not at all. I'm absolutely fine. Fit as a flea for my age.
Fantastic. And do you take any regular tablets from your doctor?
No, not at all.
Okay. And just remind me, do you have any allergies to anything?
Get a bit of hay fever, but
Brilliant.
that's really
not to any antibiotics that we know of.
No.
Fantastic. Okay. So I'm just going to ask a couple of general questions, if that's okay, which might be slightly weird, but because, as you say, we're a sexual health clinic, we kind of do look a little bit more into kind of people's sexual health. So are you seeing anyone at the moment?
Well, it's a bit complicated, actually.
Okay. So have you got a kind of regular partner you're with, someone long term?
Yeah, I've just actually split up with my wife.
Okay.
It's only just happened recently in the last couple of months, and
how long were you together with your wife?
12 years.
12 years. Okay, and you've recently split up. Okay.
Yeah.
And in terms of a kind of any sexual relationship with your wife, when was the last time you might have had any sex with her?
It's a bit difficult, really, because it's sexually we don't really have a lot between each other, to be honest with you. Not for a number of years now.
Okay. So basically, in terms of a kind of physical relationship between you and your wife, it's kind of fizzled out a little while ago. Is that right?
Yeah, it has. Yeah.
Okay. And can I just ask roughly how old is your wife? Is she a similar age to you?
She is 42.
Mm-hmm. Okay.
So it's a few years younger.
Few years younger. Okay. And so if you told me that you're now not with your wife at the moment, do you have a kind of current sexual partner that you're seeing?
Yes, I am. I'm seeing a really nice lady, actually.
Mm-hmm.
It's nothing serious.
Mm-hmm.
But yeah, we've had sex a couple of times, and she's my age. She's my age,
Yeah. Okay. So in terms of being physical with your new partner, when was the last time you two did have sex together? So we are Tuesday today.
Oh, it's been a while because she's been away. She works away a lot, so I'd say it's about 2 or 3 weeks now.
Okay, 2 or 3 weeks ago.
If not more, actually.
And by any chance, when you have sex with her, do you normally use any form of condom at all or anything like that?
No, I had a vasectomy.
Yep, you had the snip
a few years ago, and she's of a certain age where we don't really need to be honest.
Okay.
So no, we don't.
I understand that. And then also going back a little bit further, when you used to have sex with your wife, were you using any condoms at that point?
No. Like I said, I'd had the vasectomy anyway.
Yeah.
Because it's like we've got enough children now. We've got 3 teenagers. And we don't want any more,
No, fair enough. And then just kind of one further question in terms of kind of sexual relationships. When was the last time you had sex with somebody different not your current kind of new partner, and not your kind of wife. Has there been anyone else?
No, not recently. I mean, I was married before, but
no, not at all. As you say, it's something we always kind of ask. We just kind of go back a little bit just to be sure that we've kind of just asked about any partners at all. So thank you very much for answering that. And in terms of your current partner, has she noticed any symptoms? Has she said it burns when she pees, or has she told you that anything doesn't feel right down below for her?
I've not told her, to be honest. So
I
don't
understand.
know. I speak to her on the phone, but I haven't seen her for, like I say, a few weeks now.
Okay, well, okay. Thank you very much for that. So you told me that you've seen your GP and had some antibiotics for a urine infection. Did the GP collect a urine sample from you and send it to the lab by any chance?
Yeah, he did. Yeah.
And did they report back that was kind of all clear and negative at the time?
According to the doctor, yeah, it was.
Okay.
There was nothing. There's no problem. Like I say, I've never had any problems down there at all.
Okay. So in terms of coming to my clinic, I think the GP's made a kind of a good decision on that front, because there's actually quite a few different reasons as to why a guy can find that it burns when he pees. Some of them can be very straightforward, like a urine infection, but some of them can be in relation to something like a sexual infection. I don't know if that had kind of come across your thoughts at all.
Well, no. Well, like I said, I don't go anywhere. Me, I'm not that type of person. And the lady, she's not like that either, you know. So it never really came across my mind, to be honest with you.
I totally hear where you're coming from, and I'm not trying to imply that you've done anything wrong or your partner's done anything wrong. Sometimes these things do happen, and what we do sometimes find that with new relationships, that people might not necessarily know people's previous histories and may or may not have had any checkups in the past. So what we do offer would be yourself a checkup today for sexual infections, and then we'd also offer your partner a checkup as well, to be sure, because if there is something there that's causing irritation of your water pipe, what we'd be worried about is if we treated you today and then perhaps didn't treat your partner, the next time you two have sex again, it might come back again, and that would be incredibly frustrating and a bit of a damper on your sex life.
So what do you think it is then? I mean, is it, you know, I mean, because these can be serious, can't they? I mean, does she give it to me then, or if I give it to her, or?
It's very difficult to say on those things. So that's why we always recommend kind of couples to come and get themselves checked. And what we usually say to people, it's a good timing. If it's a reasonably new relationship, it's a good time to get yourselves both checked before things go on a bit further. And in terms of what we're worried about, it may be something very straightforward and using medical kind of acronyms and abbreviations. There's something called NSU, which means non-specific urethritis, which is just basically irritation of the lining of the penis, and that's treated with a course of antibiotics. If we're looking at other infections, it could be something a little bit more kind of unexpected for you, which would be something like chlamydia or gonorrhea, but are equally treatable with a different course of antibiotics.
Right, okay.
So as you say, I can't tell you exactly what it could be without arranging these tests, but I think it's definitely a good idea to get these tests done. And then we can get you on the correct treatment that you need. And then we can also then perhaps talk about getting your current partner in to be checked.
Right, so should I tell the lady I'm seeing now that she's got to go and see a doctor, or she's got to come and see you, or?
So what we'll do is we'll arrange some of the tests today, and we'll have a little bit of an idea before you leave the clinic today what we're dealing with. So we can do something by taking a sample today and having a look under a microscope. We can have a look to see if there's anything barn-dorly obvious that we need to treat today.
Okay, right.
If we don't see anything barn-dorly obvious, we send them all off to the lab, and then we get the results back to you in about a week. In the meantime, when you leave clinic, there's two options. You can speak to the lady that you're seeing and saying, look, my water infection hasn't got better. I've been up to the clinic for a checkup and I'm waiting for my results. Mm-hmm. And the doctor up there suggests perhaps you'd like to come down and get a checkup as well. Right, that might be the easiest way to say. Or alternatively, if she feels more comfortable in going to talk to her GP, she could also go down to see her GP to say that my partner's been down to the clinic and he's being checked up they don't have all the results back yet, but they've recommended I get a checkup too. So
Right.
we're happy either way. We're happy either way. If she wants to come to us, we'd very happily see her. And if she feels a bit more comfortable seeing her GP or her practice nurse, we'd also be happy for her to see them.
Right, okay. Well, I guess I suppose I need to have a word with it. Can I ask a question?
Of course you can.
So the tests we do today, will my GP, will he know what the results are? Because I've been with my GP now for a really long time, about 20 years, and he's my family GP, and I don't want, when my wife's concerned, I don't want her really knowing what's gone on. We're separated, like I say, but she doesn't know about my friend.
About your new relationship, yeah.
That's right. So so it's like, you know, I don't really want to, I guess I would have to tell her, but, you know, I don't want her to find out that way, or I don't want my doctor to know. I mean, is that something we have to do, or?
No, absolutely. So because you came to our clinic, we keep all the information here. We don't actually link it up with your GP records.
Oh, okay.
So generally people who come to our clinic, we give you a different number, we give you a different kind of patient ID, and we send all the tests off. So even if your best friend or your kind of ex-wife works in the lab, she wouldn't actually be able to identify you.
All right. Well, no, that's good. That's good to know.
So it allows you that confidentiality to have the test that you need to have. So in order to be able to get any treatment that you need, rather than worrying about who can see what.
Right. Okay, no, that's fine. So tests, I suppose, is it?
I think it would be. So if you're happy to proceed, I can talk a little bit further about what tests we do today, and then we can make a start on that, if that's all right.
No, it's fine. Yeah, yeah.
All right then, David. Thank you.
Thank you.
Great. Well, welcome back, and thank you so much, Mun-Yee. You're so wonderful at your job. I even working in sexual health, I would still love to come see you as a patient. So thank you. I guess yeah. So somebody's just popped on about remote consultations due to COVID. Let's come back to that in just a moment. I just wanted to ask you, Mun-Yee, sort of. And I know it's probably a very difficult question to answer, but how typical was that consult for you? And what would sort of some common things be that might come up in a consultation?
Interesting question, Amanda. We do tend to find people's first visit to our clinic, whatever age it is, particularly nerve-wracking. But certainly we definitely do find, for want of a better word, the shift demographic of the over 45s. Often for them, it is the first time, and they may not have come as younger people at all. And if they are coming in as a slightly older person to a sexual health clinic for the first time, it's embarrassing. Back in the day, pre-COVID, when we had waiting rooms, different age groups of people sitting there and people worrying about who was there. So that kind of embarrassment probably is still around, but hopefully is slightly less because of the fact we technically have less waiting rooms. But certainly talking about the questions, and I think what David, our simulated patient, was going through is very, very common to what people present with. So often they have been to their GP and they have had kind of particular issues that have been going on and they haven't quite settled. And then suddenly the GP goes, please go down to the clinic. It's like, oh, really? Do I have to go? So that kind of slight kind of, oh my goodness, you know, why? And hopefully we can reassure them a bit like what we did there is, you know, this is what we do and we're here to rule things out. And if all our tests are, for want of a better word, negative, and it's not anything to do necessarily with a sexual kind of infection, they can go back to the GP and perhaps have other issues dealt with. But also you tend to find that people, once they've been to us, they're kind of reassured by the fact that we've actually, I have to say, we have heard and seen everything, any story, any relationship, anything casual, anything regular, we're here to help. And I think that's what me and my team and all the colleagues around the country that work in sexual health are here to do, is really provide people with the information that they need. And if it happens to be tests and treatment, we do that as well. But information is really key.
Thank you. And following on from that, what do you think? A lot of people, I've heard just anecdotally as well as in my professional life, will say, I went to the doctor and I was really surprised that, they said that they see this all the time. What kind of things come through your door that people are often, very anxious about that actually you see every day, if not more?
So most of us tend to see patients with kind of very non-specific symptoms that might not mean a lot. So you can get something, for example, like dry, itchy skin down below. And because it's down below, some people sort of sit there going, okay, is it something sexual? Is it not? So it could be something literally to do with the change of skin down below. And there are lots of different reasons behind that. It could be hormonal, could be age-related, could be an infection. We can keep going on. But we can start that ball rolling, that process going on. Or, for example, like David, you could have something that's a little bit more kind of discreet with the genital area. So, for example, burning when you pee, discharge, potentially ulcers and breaks in the skin. Those do have sexual infections as part of their kind of cause, but also don't have to be. So again, we can start that ball rolling with doing certain tests, include or exclude something, and then potentially treat on that. So we do see so many different presentations. And sometimes we see people who've been contacted by a partner. A partner may say, I have an example, chlamydia, which is the commonest sexual infection in the UK. So an ex-partner says they've got chlamydia and they've rung through, sent a text or something like that. And they're coming to the clinic going, oh my God, I've slept with someone who's got chlamydia. What do I do now? So we can see those presentations as well. So everyone's different. And our job is to try and elicit kind of what's been going on, elicit the story and help where we can.
Thank you. And I'll open this next question up to the whole panel. Although Mun-Yee, I imagine again that you've got some sort of specific experiences. But I guess what I'm wondering is, what do you think are the regular issues that are experienced by people over the age of 45? And so more specific to the older age groups. And also, what do you think prevents them from getting to see you or, getting to come to a sexual health clinic or to get some sexual health advice? I'll start with you if that's okay, and then I'll just open it up to the rest of the panel.
So in terms of kind of older people, if we're saying people aged over 45, as you say, what I spoke about earlier in terms of having general symptoms is often the most common thing that we get. So for whatever reason, something's not right down below and they want to get checked. However, we do often tend to find people have perhaps stewed a little bit over things. They might think, okay, it itches down below, or there's a funny smell down below. And they might think, okay, it's got nothing to do with sex. It's got nothing to do with me getting older, me going through the menopause, etc. And they'll kind of just ignore it. We do find people who may think, okay, it'll go away in a few weeks. And then we also find people do come to us with potentially issues with regards to, as you said earlier, aging itself. So we do see people with what we call erectile dysfunction. So perhaps guys who want to have sex and perhaps things are not working as well as they could. And for the kind of the females and the women that we see, again, through the menopause, we sometimes find things like vaginal dryness, pain with sex, so that there can be kind of signs of normal aging, but causing them problems, and we can certainly help with that. So again, as I said, it's very different and very individual for everyone, and hopefully we can find out their stories if they come. But if they don't want to come to us, they won't come. And what we want to do is try and encourage people to access support however they want to. And if they want to come and see a service like me, that's great. But if they want to see other people, hopefully they can get help elsewhere as well.
Wonderful, thank you. Steve, do you have any thoughts on that question?
Yeah, I was kind of sitting here thinking about my own kind of work life. I've been working within kind of sexual health for the last 10 years or so. And when I started off, it was on a project with young fathers. And it was the whole time where everyone was talking about teenage pregnancy and young people and sexual health, and sexual health clinics were being set up for young people at times that were suitable and available for them. And I think kind of in the last 10 years, I've seen a little bit of a shift where people are saying, but there are other people outside of this. And having looked at some of the public health data that's available, just kind of Google public health, sexual health data, and you can have access to it all. You can see that sexual sexual infections have actually increased for older people, while at the same time almost gone down a little bit for some of the younger people. So there needs to be this kind of whole view of whole life, and not just, well, we need to kind of make services available when people are young, and then it will all be all right, sorted after that. So yeah, I think that's some of it. There's kind of changing landscape, and people realizing that older people are still having sex, and some people their relationship status changes in the scenario that they just ran through on the screen. People's situations change, different kind of partnerships kind of take up and they kind of end. So yeah, the world is a different place. It is changing, and I think people are becoming a little bit more understanding that older people do actually still have sex.
Ross, do you want to jump in?
Yes, my views would be around kind of very similar to the previous, that kind of these are this age group are affected, have the same sexual health issues as everybody else. So all those issues that we know exist around accessing services or seeking information around our genital health or our relationships and sexual health, all those issues of embarrassment, stigma, shame, worry of being judgment are universal to whatever age groups, as I think as previously been said. I think there's also something to acknowledge the fact that we are in a new age where there's more freedom and I think more choice for people, and I think we need to just encourage people to be open and honest about coming forward, about getting advice, about seeking out sexual pleasure and what they need to remain sort of sexually healthy in 2020. And I think, you know, when COVID is dealt with, and we hope it is, there will be a new opportunity for people to re-socialise. And I think we need to make sure that we acknowledge that these issues are universal, regardless of age, and we need to make people can access the support and information they need to keep healthy at whatever stage of their lives.
Ian and Tess, I'm not going to come to you just at the minute, just because I know that your expertise really for the project is around evaluation. So just so that the users listening don't think that they're just quietly sitting, it's because they've got a very specific focus. But I just wanted to sort of elaborate on what you guys have all said a little bit. And you know, so I've worked in the field of sexual health for probably 15 years, almost, yeah, maybe a little bit longer. And, you know, a lot of the funding, I've worked sort of in various areas. I've worked sort of in research, and then for the government, and now for the third sector. And, you know, what I have seen in my career is that a lot of the time the services follow the funding, and the funding is often allocated towards young people. So for example, many of you will know at the moment that there's a real push for young people to be offered universal relationships and sex education. And there's been a huge and very much needed campaign to make that mandatory in 2020. A lot of the chlamydia screening and gonorrhea screening services are focused on free. Well, they're always free, but you know, they're really opportunistically promoted to young people aged under 25. We do a lot of sort of one-to-one work with under 25s. We talk to them a lot about consent, about pleasure, about what a healthy relationship looks like. And we don't necessarily do the same thing for adults. And people over the age of 45 who I have spoken to, they say that they have either had no sexual health education whatsoever, or they've had terrible sexual education that focuses either on, you know, religion or abstinence or, you know, monogamy. And of course, that isn't the reality for so many people today. And it never looks at pleasure, and it never looks at, you know, why we actually have sex, which a lot of the time is so that because we enjoy it, we want to connect with ourselves and with other people. So I suppose the questions I would have, just, you know, with that in mind, is I'll open it up to the panel and I'll just take hands. But, you know, what would the key messages be that you'd want to get out to people over the age of 45, as well as to the people supporting people over the age of 45 around sexual health and pleasure, and, you know, sort of what they can do to promote it? Ross?
I'll take you up on other bits working with the professionals that work with this age group. So as part of our involvement in the Shift project in East Sussex, we've conducted some focus groups with a range of different professionals that work with this age group, you know, in their day-to-day work. And it was very clear that people just wanted some additional training to support them in getting over the awkwardness of it. So I think for me, the request would be to encourage the workforce to access some training and be a little bit braver in asking some of those questions if if they need to. And I think the most sensible way to do that is always talk about relationships. Nearly all of us have a relationship with others one way or another. And that's a sensible way to think about the sexual and intimate relationships that we have with people. So quite often the workforce are doing things like safeguarding, and they're checking if people are vulnerable in their broadest sense and if they're okay. So it's something about developing a skills and knowledge-based training program which enables those professions to ask the questions and maybe seek a little bit more information about the people they're supporting.
Great, thank you. Ross. Mun-Yee, you had your hand up.
Hi. So yes, I mean, it's such a big area, sexual health. For me, I can talk about sex all day, every day.
Yeah, I was going to say that's what they pay you to do.
Exactly. But I think it's really important from a kind of population and people aspect. And I'm really keen for people to make their sexual health as important as their physical and psychological health. And I also think it's really important that people have the sex that they want. Some people will have lots of sex, lots of partners. That's what they want. Some people don't want to have sex, but they still want to, as Ross and Steve have also said, intimacy, relationships, so they can have the relationships that they want and feel supported, comforted and safe, especially scary times during COVID. And I think it's also another important message to put out to people is sexual health and having good sex is not just about sexual infections, which obviously is what I deal with, not just about contraception, but there's kind of a lot of other things around sexual health and making sure people have kind of information about that. And if they think they might have an area that they're worried about, or they just want to ask a question, maybe finding ways of getting that information that they can access easily and can support them and help them make the decisions that they want to make.
Thank you. Steve, did you? Yep.
Yeah, I think my kind of thing would be about not not putting health into service. That's all, baby. Thank you very much. It just wasn't going to happen there, was it?
It wasn't coming out, was it?
Yeah, it was that word. Yeah, don't do that with health. And kind of look at health in the whole. When we take a car to the garage, we don't just say, can you just change that one tire and ignore everything else on the entire car? So when somebody goes to see a medical practitioner or kind of health trainer or somebody that's going to have that kind of touch point moment with their life to talk about health, or look at health in the whole. So somebody that attends the doctor for their diabetes, well, are they having conversations then about erectile dysfunction? Or a woman that goes sort of perimenopausal, are they going to be then talking about vaginal dryness and the effect that can have on relationship? So it's kind of looking at health as a whole, not just in little boxes. I use that as a phrase, it's easier.
I don't blame you. It's very easy to get your words muddled. But I think, you're all absolutely right. And for me, it's a little bit of everything. What you've all just said is that, and I suppose the word that comes to me, which is a much easier word, is stigma. And a lot of the times we do compartmentalize sexual health because people still feel a big stigma around talking about sex. And like Mun-Yee, I spend most of my day talking about sex and sexual health. And so it's very natural to me. It's very normal. And I sometimes, quite often actually, find myself surprised when I'm in, a social setting or in a non-professional setting, and I'll reference something to do with my work or to do with sexual health or, relationships, and it makes people really uncomfortable. I can think recently somebody in my family, I won't say who in case they're listening, had a little problem with their prostate. And they were worried about it. And, of course, if they'd just spoken to me, I could have said, I could have allayed the concerns because it was in no way, shape or form something I didn't think to worry about. And, I would have just said, your GP's fine. They'll be able to give you some antibiotics for that. But, it's the anxiety and the not knowing and the sort of shame around it that makes people not want to talk about it. And I think that we as sexual health professionals, but also just more broadly as, the wider workforce who are trying to support this age group, if we can't talk about sex and sexual health, then how do we expect the people that we support to? And one of the things that often surprises me when I do sexual health training or education to professionals, and the intention is, of course, always to do the training so that they can support their service users. And more often than not, I realize, oh, I'm training them. They don't know this. They've never had anybody talk to them about safe anal sex, or about, exactly as you say, Steve, vaginal dryness, or about, a reduction in frequency, or, any of the things that are very, very common. They've never had anybody talk. So how are they going to talk to somebody else? So I think there's a lot to be said for that. And then the other thing that you all sort of touched on a little bit was just around healthy relationships and consent. And I was very surprised to read a few weeks ago when I was just preparing for some of this work. I read in the NatCell study, which hopefully I'll be able to link somehow later, that we're actually seeing that reports of non-volitional sex, so sex either without consent or sex maybe that was not necessarily forced, but not an active consent, is actually becoming more common amongst people the ages between 35 and 55 than it is amongst young people. And I guess I just, I wanted your thoughts on that as the panel, but I also wanted your thoughts on, for you, what does it mean when you look at the combination or the intersection of healthy relationships and what that means, and consent and pleasure? And, what does that mean for people over the age of 45, and how can we promote it? I guess as just a general question. It's a complicated one. Yeah, the Ross?
I think it's a very good question. And I think that there isn't going to be one size that fits all, is there, here around kind of, the phrase around kind of the best sex and the least harm. And, I think least harm is not particularly helpful, because we want to have no harm, of course. So, of course, we want to have no harm, but we've got to accept that kind of there are some risks in types of unprotected sex with multiple partners, and that might be the best sex to you, but there might be some harm there from pathogens and bacterial STIs, etc. So, I think for me, it's a really complicated question that you've just posed there, and I think that because there is no one size fits all, we just need to encourage dialogue between ourselves as practitioners, ourselves as a sector, and also between the communities that we work with and the individuals that we work with, if we're doing that kind of work. And I guess that way we don't put people in boxes and think about what works for us and have a systematic rule to people. We encourage that dialogue and allow people to share with us what is pleasurable for them, what is the best for them, and we support them to reduce the risks if and when they exist.
Thank you. See if anybody else wants. Yeah, Mun-Yee?
So as Ross has said, it's such a kind of vast topic, but I think again it's about empowering people with information that they need, and as I said earlier, allowing people to have the sex that they want. And it is communication, it is dialogue, both within that sex relationship, whether it's a relationship of once only, or whether that is potentially a relationship that's much longer. And as you rightly say, in terms of consent, we want people to be able to have the sex that they enjoy. And if they say, actually, I don't want to have sex today, that's absolutely fine. And that people should be aware of that. And it's looking also at health promotion in terms of how we can support people to have the sex lives that they want. And as Ross has said, to reduce infections. So, for example, the kind of big thing at the moment is HIV prevention across all age groups and across all genders and sexualities. So to try and allow people to have the sex that they want and not put themselves in harm's way as much as we can. But if there is concern, if there are concerns, if someone is in a relationship where there's elements of domestic violence, we want people to be able to reach out to the right services and get themselves the information that they need. And certainly within lockdown, and we have been seeing increased calls where people have unfortunately been at home, perhaps with a perpetrator, which the relationship may have not felt as difficult when perhaps X and Y were going out to work. But when X and Y have been furloughed and at home, and perhaps that dynamic has kind of blown up, for want of a better word, and then some of those scary things happen, and how do we support people's safety? So it is a massive spectrum, and I totally agree with Ross, there is going to be no one size fit all, but it is just to say that there is
information out there, and how do we link it all together, and how do we get people who may not have put themselves in a position that they were aware of, but might want to think about what they could do if they needed to kind of access help or support.
Thank you. Yep, Steve?
Yeah, it was just, again, I spent quite a lot of time reflecting, thinking about when we were young, and kind of the awkwardness of getting involved in relationships and the whole kind of consent and kind of talking stuff through, and how awkward all that can be. Well, I don't think that changes when people get older, particularly if they've been in a long-term relationship where everything's settled. People don't have to kind of ask the questions as much. People know what people like and what they don't. They know when kind of consent is being given. They know when it's not. So to then be put in a position where you need to kind of go back to that learning stage when you were young, that you were in as a young person, but as an older adult, I think that's a whole new territory that people need to find their way through. And again, it's another reason we just need to have the openness and frankness to say, yeah, these are real genuine questions. Let's talk about what consent really means. Let's talk about what you do like, what you don't like, what your kind of likes and dislikes are, and have those conversations. Yeah, they're going to be awkward, but I think we do need to have them.
I completely agree. And, I think what comes up for me in everything that you guys have all just said is that, what good sex is for people is, for every individual, is going to be as individual as that person. But also, I think with age might come change. And, maybe you got into a relationship 20 years ago and you're still in that relationship, but your body has changed, your desires have changed, what makes you happy, what turns you on might have changed. We see people who are getting out of heterosexual relationships and looking into different attraction to different genders, a relationship with just different genders. They're exploring their sexual orientation publicly for the first time, or maybe they're in, they've been in a long-term relationship and they've left that long-term relationship and they've got one or more new partners. They might be exploring non-monogamy. They might be exploring, swinging. There's a whole bunch of things that can come up later in life, throughout the course of your sex life. And, we all need to understand that what worked for somebody, at one age mightn't be the same thing. And as you say, it's about talking about that and feeling comfortable to have those conversations, knowing how to bring them up and when to bring them up. And I suppose knowing where to access support. I think this is a really good segue actually into the next question, the next topic, I should say, that I wanted to go over today, which is around, what are we actually doing in shifts? So we've had all these, these great conversations about why it's important to look at sexual health in the age of over 45. But obviously, we could talk until the cows come home about what we think is the problem, but it's not very useful unless we actually go to the people who are over 45 and ask them, what's coming up for you guys? What do you need? What would work for you? Where do you want to talk about sex? How do you want to talk about it? What are your relationships looking like? Who are you with? All those sorts of things. So this is where Ian and Tess will come in. And I'm so sorry that you guys have had to sit there so quietly so far. But I just wondered if you guys could both maybe give us a little kind of update, I suppose, as to what we've done so far in terms of asking people for their feedback. And, if you could just give us a little bit of an introduction into what we found so far, what's come up.
Thanks, Amanda. I found the whole discussion so far really fascinating, and it's really important. I think from our point of view, so the first survey that we put together for the whole team, for the whole partners in the Shift project. So it was accessing people over the age of 45 in the UK, in Belgium, and then the Netherlands, and we had it between 200 and 300 people in each of those countries. So there was 777 in the initial survey sample. And what we learned from that is that the majority of people don't see themselves as at risk. So that simulation, I thought was an excellent simulation with Mun-Yee and Stewart, is that same idea that they don't perceive any risk, because a lot of them seem to report that once you go beyond a typical age for conception, so if you don't think that pregnancy is really going to be an issue, you don't think there's going to be any issue at all really around sexual health. But what we found, what we're really pleased to find, is that over 60% of the participants over the age of 45 were reported still being sexually active, and find that sex is a very important part of their life still. And there's only a very small minority who were not sexually active or hadn't had sex over the last 5 years or so. So within that sample, we had about 425 would identify as being heterosexual or straight, 104 were identified as being gay or lesbian, and about 46 were bisexual, and there's also a small portion who were asexual, who kind of reported that they used to have a high sex drive, but just simply didn't feel the need for it anymore, and they had no desire for it. So in terms of the relationship status within our sample as well, so 347 were married, so just over half were married, over 100 were in partnerships, and a small sample, only 27 were widowed, which is quite small. We expected more of that in our sample because there's a broad range from 45 up to 80. And the divorce, there was only about 85 were divorced. We expected a lot higher because certainly here in the UK, the divorce rates are in around one in every 2 marriages. So they also reported that they didn't see themselves as being at risk. There's only a tiny proportion saw themselves as being at any risk. And in terms of the knowledge, just less than half said that they felt they had reasonable knowledge about sexual health and any potential risks that might be out there. And this mainly reported pregnancy as their main thinking. And once they're gone beyond that, they weren't thinking about sexually transmitted infections. And particularly those ones, like in simulation, when you're moving from that, maybe you're in a long-term monogamous relationship, and then you move in your 40s or 50s or 60s to a new relationship or to multiple partnerships. That stage, so you just don't think there's any risk at all. That definitely comes up in our survey as well. But we're really pleased in the survey, and I'll let Tess as well talk about our interviews as well. We also carried out interviews with telephone interviews and focus group interviews with partners in each of those countries, and they're really rich data source. And what I take from that is how articulate people are really about their sexual health and their needs, and how strong their sense of self still is. It's not like that you suddenly stop being yourself at 45 or 50 or 55 or 65. You've still got needs, you've still got desires, you've still got yearnings, and sexual health is an incredibly important part. And as Steve was just saying earlier, that it's just as important as our physical health and as our psychological health. It all comes together. So humans have that need for desire, and as Mun-Yee and Amanda and Stephen was saying as well, it's implying that especially this year we still have that need for human touch and intimacy, and to perceive that as normal. But they also do report that doctors particularly don't seem to know how to speak to them about that, because it doesn't really come up. Like as Mun-Yee said, they might ask about specific physical ailment, like a dry, say, vagina, or a man reporting, say, a particularly unpleasant itch, and so on, and what to do. But they don't really delve into what their sexual life is, and how normal that is. So it's the stigma that Amanda was talking about that comes up time and time again in it. And that like there's almost a sense of shame there, or that there's something silly about you. You can talk about sex when you're 52 years of age, or you're 4 years of age. But we're just trying to get across in this model that it's absolutely very, very, very normal, and it's very healthy to have an active sexual health if that's what you want in the middle to older age, and that your desires and your drives don't change. One thing that does appear in some of our surveys and our interviews is kind of a mismatch in sexual drives between partners. And so maybe in a partnership, the sex drives were perceived as being fairly equal, maybe in their 20s and 30s and early 40s. But then things change, and maybe the man or the woman or both men or both women and so on might in that relationship just their needs change, and that's where a lot of kind of issues around sexual health and frustration come in, and then they think there's something wrong with them because they still want it, or they think their partner still wants to have a lot of sex, but they don't want it themselves anymore, don't feel the same need or drive. So there's a lot of support that we can give that isn't really readily available in, say, many typical GPs. But we see in Mun-Yee's training there, Mun-Yee's expertise in this, and how comfortable Mun-Yee is at talking about these issues. and exploring them. But many health practitioners probably haven't been trained in that. They're used to talking to maybe 17, 18-year-old, 19-year-olds about pregnancy and about sexual transmitted infection. But as Steve pointed out, the biggest rise in sexual transmitted infections is in people over the age of 45. So we have to increase knowledge and awareness of this, and access to sexual health and resources and health professionals. And we have to reduce the stigma and make sure that it is a very, very normal, healthy part. But as I was saying, just to finish up, that I'm very impressed with how comfortable people were in these interviews and in their surveys about reporting on their sex life and their understanding of their own desire and need for it. So I think that's something very positive to work with, and we just have to increase knowledge, awareness, access, and to reduce the stigma. I can bring Tess in here if Tess wants to add anything.
Yeah, I mean, I think Ian, you covered so much there, and obviously, you know, like he said, the interviews were so rich with data that we can't possibly cover every single thing today. But hopefully, our Twitter page and website will be linked so people can kind of explore those in their own time. But I think, like Ian said, you know, all along the kind of help-seeking process, there are kind of things that come up in interviews and surveys. So, for example, you know, there is this general lack of awareness of, you know, why would I need to go to a sexual health clinic? Why would I need to talk to my GP about this? So I think something that we want to do with Shift, like was kind of mentioned before, is this, you know, just because you might not have a kind of physical symptom, for example, of an STI, you know, sexual health and well-being is much more than that, and it's much more of a holistic thing, you know, including emotions and relationships, etc. And then obviously, as we move along kind of this help-seeking process, you know, someone might think, oh, you know what, I want to go and talk to someone about this, but we find that a lot of people just actually don't know what services and what support is out there. You know, a lot of people say, well, isn't this clinic just for young people? And I think that really emphasizes kind of why this project is needed, you know, for this particular population. And I know that stigma has been mentioned a lot, but if we kind of delve into that a bit deeper, there's lots of different kinds of stigma that are felt by this population. So of course, you know, people are fearful of being judged by the wider society, but they're also some are fearful of, you know, what the healthcare professional themselves might think, you know. And I think one participant put it quite well, that they'd just really like to see someone who looks like them, you know, that they can go and talk to, and having that kind of equal kind of playing field, I guess, can really facilitate this kind of open relationship. Other than that, I think Ian covered a lot. If there's any specific questions, I can give them a go at answering those.
Sorry, the eternal problem of putting myself on mute. It's funny that you said that last sentence, Tess, because you know, one of the things that I've learned over the years is that the preference to see somebody who looks like you is very different across very different cultures. And for some people, it's very, very important to sit across from somebody who looks like them, who sounds like them, you know, and who may have, you know, similar cultural or social experiences they do. And that's really, really important to some people. And yet to other people, they actually want the opposite. They want it to be as far removed from their culture as possible, due to concerns around stigma, around people talking, around people gossiping. So it's very, very interesting. And I think, you know, what that does remind us is how important it is to ask and to have options for people, you know, to not assume that the one size fits all model is going to fit all, and to make sure that we have, you know, different spaces, different locations, different types of people, you know, different levels. So, you know, some doctors, some nurses, some community practitioners, some lay people, to make sure that we're really getting to the people who, you know, to the people who need it in a way that works for them. And I think that's the key. But I wanted to ask both of you, and just because I found it fascinating that for two people who don't have a background in sexual health, you guys have both talked so beautifully and eloquently about sexual health. So I just wondered, for you guys who both have, you know, an incredible academic and research background, what has surprised you about, you know, being in the Shift project? What have you learned? But also about what the research, you know, was there anything that surprised you in what you've read so far? I'll start with you, Tess, this time. Oh, no. Okay, Ian's going. Okay, Ian, you go.
No, so I don't want to override Tess at all. No, what I've been really impressed with, again, as I said, it's just how strong the person's sense of self is, and that in your mind you don't grow older. Like you still might feel that you're in your 20s and your 30s, and that you're still entitled to have this life and to live this way, and for this to be an really important part. And I've learned a huge amount from working with you, Amanda, from working with Mun-Yee and Steve and Tony and Stewart and everybody within the project, and our partners in Belgium and Holland with Tatiana and Luca and Kate and Nick and so on, is that everybody brings something to it. Well, I'm really impressed with your knowledge and experience, and just the diversity, and even visiting your charity in London, and just sitting there and just observing all the walks of life that walk through your door. And just the diversity is absolutely incredible. And I find it really life affirming. And some of these people might be considered on the margins of life, but they're walking into your door and feel very accepted, and they really do belong there, and they all very much belong in life. I think what this has shown me is that we all need to belong, and we do desire these relationships, and we do desire that connectedness to others. And as I said earlier, we do have these yearnings. But from an academic point of view, I've conducted a lot of surveys over time, and we've certainly conducted a lot of focus groups and telephone interviews over time. But as Tess was saying as well, I've been kind of blown away by the richness of this data and how articulate they were and how they understood their own needs. They mightn't have had the exact words when I say to articulate, they mightn't have known the exact, say, sexual health term that you will know, Amanda, and Mun-Yee will know, and Steve, because that's your area. So they won't have the correct technical term per se, but they will know what they're feeling. And also, but I've also been aware that we do need to do better. Like, it's coming from that they don't know who to go to, as Tess was saying, and they mightn't feel comfortable speaking to, say, maybe a young nurse, for example, and they want to see someone who has been through life and seems to understand their particular needs, and not just give the same answer that you would give to a 21-year-old who might be in their first relationship or having their first child, and so on. But it would have been just how diverse and beautiful life is. I think that's one of the biggest things in this project, and the drive among the whole partners to make things better, to put something in place, to allow people to flourish and to thrive in life, and not just to survive. And this is not all about just combating sexual transmitted infections. It's about encouraging and flourishing and thriving and living a happy life. And this is a very important part of that, as Steve was saying.
Wonderful. Thank you. Such beautiful and eloquent words. Thank you very much. Tess, I feel like that's going to be a tough act to follow.
I know he has articulated it all so well. So I
you need to be on the radio.
Good. Yeah. I'll just kind of reinforce what he was saying, really. I mean, I think there is this stereotype that older people are asexual, and I think something that's really important about this project is it's really breaking down that stereotype. And like Ian said, when I'm looking through these interviews, for example, like, it's just so clear how personal and complex sexual health and well-being is, and how it touches all aspects of people's lives, and kind of is channels through their lived experiences throughout their life course. And I think, that's something that's really cool about this project. And I think also, this interdisciplinary nature of Shift, and like bringing all this expertise together across borders is something that's really unique. And it's a really great project.
I'll open it up to the rest of the panel for any sort of feedback on what you guys have just heard. And then what I wanted to talk about next was just, what are we going to do from here? What are the next steps? But I'll open it up because Tess and Ian, you just gave such, wonderful summaries and, really great insight. So thank you. Let's see if Mun-Yee.
Just going to echo, Amanda, exactly what you said. The summaries and the review of the data and the information that we've had from the University of Chichester has been fabulous. As everyone knows, I am a sexual health doctor. I work in clinics and I see certain people. But as we've all said, there's so much more to sexual health than just an infection. I am only part of that kind of role, and getting such a dynamic group of partners together and looking at it from as many different angles as we can, and bringing those populations in,
getting people to let us know what they need. How do we deliver services differently? What information do they want? You know, what questions are we not asking? Or, you know, who do they want to go see? I think that kind of diversity and that allowing people to individualize for their situation, their personal circumstances, and those will change over time, but allowing them that choice, I think that's really important, allowing people the choice to have the sex that they want and the sexual health that they want.
Steve or Ross, did you want to jump in? You don't have to. Oh, yeah.
Yeah, I will. I think that one of the overarching things I've really picked up from the project is the richness of the data we've got in the UK. I know that when we were sort of working with some of the other partners, and we just said, well, can't you just go onto your equivalent of the public health website and kind of pull this data off? And the answer is, well, no, we can't, because they haven't got access to that data. Now, if you're a bit of a data nerd like me, then that's a big gap that you've got. And the other thing was also then the accessibility of services, because we do take the NHS and kind of local authority funded services, we take them for granted. And when you hear some of the other partners saying that a barrier to people actually getting sexual health support is that it's going to cost them some money to actually go and get that, it humbles you a bit to think, actually, yeah, we do get a heck of a lot given to us, and we can sometimes take it for granted and think, oh, I don't need to use it, when in reality it's there, it's free, and it's going to benefit our health.
Ross? You don't?
Yeah, so just a final point for me on this, which is kind of, it shouldn't surprise me, but it continues to surprise me, and that is, you know, we've all talked about our length of time that we've worked in this field, and essentially, you know, stigma, embarrassment, and judgment still is a major issue for the public, regardless of how often we tell them that the services are anonymous, free, confidential, and all those phrases we use. So I'm surprised and reminded consistently that we must continue to tell people how anonymous and how non-judgmental our services are, and that they're available for them when they need them, regardless of how they feel they might be received. They will be received welcomely and in confidence.
Yeah, I think you're very right about that. Confidentiality that's often the concern that people have, is just, you know, who's going to find out, you know, even in the great example that you and Stewart did, or you and David, I should say, Mun-Yee, you know, they're worried, where is the data going to go? You know, people still believe in the UK that if I have an HIV test, I won't be able to get life insurance, or I won't be able to travel, or, you know, if I go to the sexual health clinic, my partner's going to, you know, think that I've been unfaithful. You know, there's lots and lots of things that come up for people, and a lot of myths that prevail. And, you know, sometimes I just want to say, no, where did you hear that? And it's sometimes very difficult to convince people that, you know, the things that they believe to be true are not actually true. And I think that actually really segues nicely into sort of the last and final topic that we wanted to talk about, which is that, so from the research that we've done thus far, and thank you, Ian and Tess, you guys have done such a wonderful job, and you guys have been so supportive and responsive to us. And I have to say, reading through some of the transcripts I sent you, I don't know how you do it. They're so long, but you know, I'm so pleased that they've been interesting for you. But so what's come up in this, I'll just summarize it for everybody listening, and then we can talk about it in a little bit more detail. But what the University of Chichester have done is summarize the kind of the responses into 4 categories. And those 4 categories that we've learned are around stigma, which is no surprise, around knowledge. So, you know, what do people know about sexual health, relationships? What don't they know? Access, and that's predominantly to do with services. So if they do believe that they need help, can they get it, and can they get it easily? And perhaps most importantly, can they get it in a way that is comfortable and appropriate to them? And awareness. So it's similar to knowledge, but a little bit different. You know, what are they aware of? You know, would they recognize their own risk? Would they recognize a service if they needed it? That sort of a thing. So I thought I would open it up to the panel and just ask the question of, you know, whether we, you know, I've learned a few things, but, you know, what do we know just at this point in the project? And again, for those of you listening, we're in year 2 of 4. What do we already know now from this research, and that we mightn't have known before? If nobody has an answer, I'll go to the next question. Mun-Yee?
I mean, I think as we've all said, that the richness of the data has brought in the fact that we really don't necessarily have all the answers, and I kind of say that because of the fact that's what this project is there to do, is to potentially provide a different way for us in kind of the UK, Belgium and Netherlands to think about sexual health provision, to think about sexual health education, to think about how we can change societal norms. It's a big thing. And I think it's something that I think we do need to try, because we can do campaigns, we can do small things which are important, but what can we change that's really going to help empower people to take their sexual health and take it as important as any other aspect of health, and as Steve has eloquently said, across the whole life course. Obviously, we're focusing on the over 45s. They have sex, they have relationships, they have issues, but yet we also know they have healthy sex, healthy relationships and no issues. So it's how we can kind of, in a way, kind of transform the way people talk and think about sex to be much more normal, much more individual, and not so, as you say, kind of hidden. And I think certainly, I don't think we have all the answers there. So it's slightly a slightly skewed answer to your question. But I think we really, the questions are being raised are, how do we change? How do we change things, and how do we improve them?
Great, thank you, Mun-Yee. And I'll jump across to you, Steve, if that's all right. Oh, you're on mute. It's bound to happen.
Oh, it certainly was. Yeah, I think one of the things that I've learned is that people aren't necessarily going to turn up to sexual health services because they don't think they're for them. So then what we really do need is what we're terming the wider workforce, those kind of front doors that people are going to start talking about sexual health, so that at least people have got a point that they can then start broaching these conversations if they don't have that confidence to turn up at the front door of sexual health services. So making sure there are many front doors into the support.
Yeah, I love that idea of many front doors. And, you know, I think we often think about sexual health services exactly as we're seeing Mun-Yee at the moment, you know, in a clinical setting. And we absolutely need that aspect of sexual health. We absolutely need that. They're vital. But sexual health doesn't have to be that. You know, it can be a quick conversation about, oh, you know, I'm not really getting on with these condoms. What are my other options to try? Or I wonder if I have a latex allergy. You know, those sorts of questions. They don't need to come and see Mun-Yee for that. We could be having those questions and those conversations in a lot of other venues. If we can upskill people, if we can get people, you know, able to A, have the knowledge, but B, have the confidence to bring those things up. And I think, Steve, you actually just raised a really interesting point. One thing that I have learned, or I suppose I was reminded, I actually learned this about, I don't know, 5 to 10 years ago when we did some research in Bromley, and then had completely forgotten. But it's very interesting that a lot of people say to us, actually, you know, I wouldn't have any problem visiting a sexual health service, but I don't need to. You know, I'm not at risk. I don't, you know, there's nothing that's changed in my life, and there's nothing unusual. So, you know, yeah, sure, I would go, but I actually don't need to. But then when you sit down and talk to them and go through their, you know, their sexual history, and go through their risk factors, and go through, you know, their pain or pleasure or any of those sorts of things during sex, you realize actually this person probably really could use an intervention and use, you know, a little bit of a conversation and some support. But either they don't understand the risk, or they're, you know, they're used to, you know, something like erectile dysfunction, they get used to it, or, you know, vaginal dryness. It's been happening to them for such a long time that they don't even realize anymore actually that it doesn't have to be like this. I don't have to I don't have to feel like this. So I think that, you know, both of those points are you know, are very interesting. I'm very aware that we're coming up to the end of our time. We've only got about 10 minutes left. So I wanted to ask you all to answer one question, and I'll give you the choice. So the first question is, if you could wave a magic wand, and, you know, you had the unlimited budget, because I know it often comes down to budget, but if you had a magic wand and you could change one thing to help people over the age of 45 have good, pleasurable sex lives, what would you do? What would you change? And I'll start with, who will I start with? Let's start with Ross.
Oh, I'm going to be. I'm going to say we've been very good at doing campaigns to all sorts of age groups, whether that be for men who have sex with men, people of BAME origin, and of course young people. So I think for me, I would do a campaign which used all the channels that we know work for reaching adults over the age of 45, and it would just encourage them to talk about the relationships and sex that they currently have in their lives, and the fact it would be to open that conversation and to try and get over the taboo of talking about the relationships and sex that the majority of us have.
Mm-hmm. Absolutely. Steve, I'll go up to you.
So back on the magic wand, I was expecting a different question.
Sorry.
I'll do somebody else on the magic wand and then
All
come
right,
back to me on that
Mun-Yee,
one.
do you have one? Yeah.
So one of the things I see working in sexual health, and as you say, as being a clinician, the focus is quite driven to sexual health management, infection management. I want to kind of take the step back and promote sexual health promotion. And, you know, whether, you know, as we say, however we do that through kind of education or, you know, awareness about aging or, you know, awareness about relationships, etc. Just having that kind of promotional element and not making sex bad, because sex isn't, it's fabulous. So having good sex is fabulous. That's what we want everyone to want at the end of this, if that's what they want to do. But having that promotion rather than, as you say, just focusing on kind of infections and test and screening, which are important, otherwise I'd be out of a job, but are also only part of someone's good sexual health.
Absolutely. Steve?
It would be to take out the snigger factor for sexual health. So when you have conversations with peers, so I'm kind of 51 now, you have conversations about sex with peers, and it's always kind of, oh, yeah, for sex. Whereas we need to kind of normalize that. And so you actually get blokes talking about what it actually means to age a little bit when you're kind of still wanting to have sex, but things may be slightly different. Me and my friends have no qualms talking about what we eat. We'd have no qualms talking about maybe needing to cut down our alcohol consumption a little bit. I don't remember having many conversations with my peers about our sex lives. So yeah, reducing the snigger factor.
Yeah, I really like that. And it's funny, I don't do it as often as I would like, actually, but when I used to do a lot more training around sexual health for young people, I always said that you had to get through the laughing wall. And it's very much what you're talking about, Steve, is that, you know, they would all, not all of them, but there would always be one or two at the beginning who would try and say something really, you know, gratuitous or really lascivious and try and get you to, you know, feel uncomfortable. And then they would all laugh. And then the way that I always sort of took that balloon and popped it was just to sort of answer the question, you know. So, you know, a big one was always around anal sex, and they would go, "Oh, miss, you know, what about anal sex and this?" And they would all laugh and think that, you know, it was going to be, you know, it was going to put me off or take me. And I would say, well, okay, well, let's talk about anal sex. And then all of a sudden they were silent. And it would be, and I'd say, okay, you know, well, you know, unlike the vagina, the anus doesn't self-lubricate. So we need to support it with that. And, you know, these are the things you need to consider, and And it was like, oh, we don't need to laugh about this. And actually, this is a really interesting question that we can answer. But like you, Steve, I've seen the older age population, they're almost worse than the young people sometimes. It's so uncomfortable for them to talk about it that they either dismiss it or they laugh about it, or they just don't talk about it at all. So I think that's a really good answer. Really, really good answer. Ian and Tess, I don't want to exclude you. Did you guys have it? Yeah, Ian.
I just really want to echo what Steve and Ross and Mun-Yee have just, as I said there, because I think when we're going through the interviews that we identify the psychological barriers to accessing services and to discussing sexual health as being normal. So we want to focus on what are the facilitators, and just to kind of echo kind of what Steve was saying there, and Mun-Yee as well, that if you think about, we always talk about sexually transmitted infections, and we used to say sexually transmitted disease, but the opposite to disease is at ease. So I just like to get us to a point where we can be sexually at ease rather than talking about sexual disease. And I think that's all about the communication, and move away from this idea that if you go to some kind of sexual health clinic or surgery, that people will know that you're going there for that reason and they'll be pointing at you, and just imagine the idea that people are trying to imagine scenarios about what you did and somehow it's dirty. And we move away from the idea that sex is dirty and that sex is something that is that should be cherished and is normal if you want it. You don't have to have it, but if you want it and to be part of your life, that it's something extremely normal, and it's a drive that we have, and it's something there to be supported, and that we can overcome a lot of these psychological barriers that we have identified, and a lot of it is around communication.
Tess, I don't want to exclude you. Do you have any thoughts?
Yeah, I guess obviously stigma is a massive barrier, and we've talked quite a lot about that, but I think in a more practical sense, it would be really good if everyone just knew where they could go, you know, and having that signposting there is really important. And obviously, you know, it might not be appropriate to have a massive poster on a building saying, you know, this is your sexual health clinic, but having lots of different avenues to kind of just say, you know, we are here and you can come and see us, because, you know, there are lots of different ways to do this. And something that surprised me actually was how a lot of participants still benefit from the traditional forms of communication, you know, having a letter in the post, an email. You know, someone said, you know, why don't you have a post in a bus stop? And I think, you know, of course, social media is great. And I think a lot of health promotion now is through those platforms. But I think it's important to remember that some people actually do benefit, you know, reading the newspaper and having a little advert in there. You know, it's not everyone can't get online and doesn't always want to get online and be bombarded with stuff on social media, but having, you know, a poster in a community setting, a letter through the door could, you know, just kind of nudge someone in the right direction.
Tessa, I think that's just such vital and probably a really good way to start wrapping things up, actually, because, and sort of going back to what you were saying, Mun-Yee, about, you know, really wanting to focus on health promotion. You know, my heart is in health promotion. I'm a health promoter. I happen to be a sexual health promoter, but, you know, my background, my love is all in health promotion and community health promotion at that. And, you know, I think what you're talking about is the fundamental issue is that if you want to connect with people, you have to connect with them in the places that they live, work, learn, love, and play. And that's a real sort of fundamental concept in health promotion. But, you know, if I'm, you know, 65 and I don't have a Facebook account and somebody tells me, oh, well, why don't you just go into Facebook and, you know, you can ask a question on somebody there. I think this service isn't for me. Why would I do that? Or, you know, and I find it sometimes, like I had a problem with Habitat the other day, and they were telling me that the only way I could get in touch with them was on Twitter. I didn't have a Twitter account. What was I supposed to do? I was like, I just want to speak to somebody on the phone. And that was over a coffee table, not my sexual health. And, you know, one of the things that is so important for people is to feel understood and heard and represented, and that their voice is respected. And if what people want to do is open a newspaper in the morning, let's put something in a newspaper. If what they want to do is, you know, attend a knitting group and have a bit of a chat with their girlfriends, let's go there and have a chat with them, you know. And it's so important to the work that we do. There's so many things that we wanted to cover today. I wanted to talk about quick wins. We wanted to talk about what we want to achieve. Although I think that, you know, empowerment has really come through today anyway. But sadly, we are out of time. So I'll just open it up to the panel for any final thoughts, and then I will thank our funders again. So let's go in the reverse order. Let's start with Tess. Let's start with you this time. Just any final thoughts and, you know, maybe a message to people over 45.
I'll just say again, you know, it's a real kind of pleasure to work on this project and to work with all the different partners across the European countries. And yeah, I just say, you know, don't be scared. You know, go along to, you know, you can just be your GP, bring it up in a routine appointment. It doesn't have to be, you know, something big and scary. Yeah.
Great, thank you, Tess. Ian, I'll pop over to you.
Yeah, just echo what Tess is saying, and generally is so what we had hoped from this project is that we'll also develop models that we can train the professionals, so we can train professionals to be more at ease in discussing sexual health needs of people over 45, and that it becomes a routine part of any kind of assessment or checkup or hospital or GP visit. And so it's nothing that it becomes so normal that no one's even thinking twice about it. That is strange. And just to know that you're not alone out there, that if you're over 45 thinking that there must be something strange or odd with you, because you're feeling this way, or you've got an increased desire that someone else doesn't have, or you got a reduced desire that your partner doesn't have, or as Amanda, you're saying, you might be a heterosexual person now with homosexual or bisexual desires you didn't have before, and you think there's something odd or weird. You're not odd or weird. There's so many people out there like you, and we hope that we put in plans in place to kind of help professionals be more comfortable and at ease in dealing with every type of sexual health concern in people over 45.
Wonderful, thank you, Ian. Has Ross gone? Okay, I'm not going to go to Ross. I'll go across to Steve.
I would say services and commissioners, we want to hear what people generally think about the services that are being provided. So if you've had a good experience, if you've had a less good experience, if you can come with solutions as to, well, have you thought about this, have you tried this, this is my experience, this is what we can learn from it, feed that back one way or another, feed it back to the service or feed it back to the commissioners, because we do want things to be better. And a great thing about this project is that it is going to come out with some kind of training materials that we can get the wider workforce to deliver the best we possibly can.
And last but not least, oh no, Ross is back. I'm going to go to Mun-Yee first, and then I'll jump back onto Ross. Mun-Yee, over to you.
Thanks, Amanda. And as everyone has said, this has been a fantastic project to work on. I'm looking forward to see what we can produce in the future, and hopefully for the benefit of anyone aged over 45, to help them have the sex life that you want. And just to be able to know what's available to you when you need it, for whatever reason.
Thank you, Mun-Yee. And Ross, I'll jump down to you. Sorry, you disappeared for a moment.
Yes, sorry, obviously some technical faults here on the front. So apologies. I'm sure I would echo everything everyone else has said. Obviously, it's just great to open the lid, I think, on this Pandora's box of an issue, really. I don't think that we can solve all the things we need to solve just within this project, but hopefully we will build up the momentum we need to make sure that we get, we continue to improve and make things better for the populations that we serve.
Wonderful, thank you. And I suppose I should give my thoughts as well, my final thoughts, which are again around empowerment. It's something that we talk a lot about in health promotion, and I think that the word can become meaningless because we hear it so much. But for me, what it means, just in relation to sexual health in the over 45s, is something that we've all said today. It's, having happy, healthy, fulfilling sexual health lives, or sexual lives and relationships, and whatever that means for you as an individual. And please, to anybody listening out there, don't think that, we don't care, that we won't be able to help you, that, you'll shock us, you won't. Our job, and, what we're all here for, is to support you and to, to try and make a difference to your sexual health, but also to your relationships and to your general well-being. So please don't, as Steve said, compartmentalize your sexual health and put it in a box never to be talked about. Get down the box, bring it out, open it up, and let us support you. So it just remains then to thank once again the Health in Europe Centre for their amazing leadership for this program, as well as the Interreg 2Cs Foundation. Is that what we call it? I don't know. European funding for their funding and support, and for taking a chance on this project, which, as everybody has said, has just been so satisfying. We're only halfway through, and we're looking forward to the next 2 years, where we're going to come up with some great training and resources, and hopefully we will talk to you all maybe next year with some more updates. If you want to get in touch, we're going to pop up the link for the Shift webpage. If you are a stakeholder, and what I would mean by that is anybody who works with people over the age of 45 and wants to support sexual health. So you could work in homelessness and housing, drugs or alcohol, fitness. I'm trying to think, people who support sex workers. You could work with BAME communities, people who are LGBTQ, anybody who works with and supports people over the age of 45. You are a stakeholder, and we want to hear from you and engage you in our great work. We're very excited about our next steps, and we hope you've all enjoyed today. Do get in contact with us if you need to, and for now, we will all wave and sign off.